Hello, my name is Professor James Wheless. I am Professor and Chief of Pediatric Neurology at the University of Tennessee Health Science Center in Memphis, Tennessee. Welcome to our program today. I am joined by Professor Katarzyna Kotulska, who's head of the Department of Neurology and Epileptology at the Children's Memorial Health Institute in Warsaw, Poland. Also, Ms. Lisa Moss, who is Vice President of Donor Relations at the TSC Alliance and a mother of a child with TSC based in Silver Springs, Maryland in the United States. In this section, we will be considering management strategies for patients with TSC-associated seizures. So first, let us maybe start with discussing kind of the clinical burden of tuberous sclerosis complex. And Lisa, you've lived this, so I mean, I think we can say it, but you probably can say it much better.
Thank you so much. I think the clinical burden is definitely pretty tremendous. Evan was diagnosed with epilepsy at age 3 months. He started having seizures within just a few weeks of life. And over the course of the last now 19 years, we've tried multiple medications. We watched him have over 2,600 seizures. He was born with 4 brain tumors. He underwent brain surgery on 2 separate rounds of brain surgery trying to gain seizure control and lots of different medications. And it seems like with TSC, there's always a surprise just around the corner. So we've struggled with having time periods where things are going really well, followed by time periods where things are going very poorly.
And I think, the challenge is obviously dealing with seizures is significant enough in tuberous sclerosis, but then there's that diagnosis on top of it, and then all the other disease manifestations, along with the frequent intractability. I know for healthcare providers, that's, I guess, the challenge from our side of the fence we face too. Is it's always seems like just as one thing is doing better, you hope everything else stays that way or something else doesn't shift too, right? It's kind of can be a moving target at times. Professor Kotulska, do you want to weigh in on maybe kind of treatment options, kind of where we've been and where we're maybe currently are with tuberous sclerosis complex?
I think we should focus on epilepsy today because we don't have time for discussing all of the manifestations of the disease. And seizures are so frequent, as many as 90% of patients do experience seizures during their lifetime. So it's really a major problem in TSC. And in the majority of the patients, seizures start in the first year of life, most frequently between the 3rd and 5th month of life. Although some may have seizures from birth, epilepsy is far beyond seizures in TSC. As you know, it's associated with neuropsychiatric disorders, and we still do not have an ideal treatment that could be really curative for epilepsy associated with TSC. Although the number of the treatment modalities increases over time, we have the medical treatment, we have the surgical treatment, we have the ketogenic diet and the modifications of ketogenic diet, and we do have the VNS. And the medical treatment includes more and more of different drugs, including standard anti-seizure medications, mTOR inhibitors, and recently approved cannabidiol.
Yeah, I think TSC is the one area where, historically we kind of borrowed, if you will, approved drugs that would work in, the seizure types we were seeing in TSC that were tested in, non-TSC patients and brought them into our TSC patients. I think probably the difference in my practice here is the TSC patients are often on many more other medications. So whether it's mTOR inhibitors, whether it's medications for behavior, other blood pressure. So the concept of being very careful with drug-drug interactions often comes up more here in my patient population. So I think often the management is a little trickier or requires more attention, I guess, however you want to think of it, than maybe my regular patient with hard to control epilepsy. And we use, you mentioned kind of the list, but I mean, we end up kind of using all the options available to us, right? And the unique difference is probably that this is the one area where we've had some unique therapies that are targeted, to the underlying disease itself to try and help us out that we don't have in other epilepsies. So maybe touch on those, if you will, Professor Kotulska.
Yeah, I'm basically dealing with young children and infants with tuberous sclerosis. So vigabatrin is a primary drug for me and for my patients. We start usually with vigabatrin, even though it is associated with a substantial risk of adverse events associated with retinal toxicity. But on the other hand, the risk of neuropsychiatric complications associated with drug-resistant epilepsy, I think it's much more important than the risk of visual field restriction. And this is, when I discuss it with the parents, this is basically their point of view, that they want to take the risk of potential toxicity much more than the risk of neuropsychiatric disorders associated with TSC.
We've had specific TSC therapies approved that are pharmacologic therapies. They've had advantages, but they also have some drawbacks too. So just kind of how those fit in. Vigabatrin, we know, is incredibly effective for TSC infantile spasms and can be for seizures in infants. We've had to balance that with the potential for toxicity to the eye and to the retina. The understanding and the use of mTOR inhibitors in tuberous sclerosis has been great for some of the other disease manifestations, as we've used those as an epilepsy drug. Many of our patients are on it for other manifestations. It can help their epilepsy, but we know that in some, it's not been as beneficial for their epilepsy. I think other hope was that it would really help with some of the cognitive and behavioral side effects. And unfortunately, when we use it in older, I would say children, adolescents, we've not seen that. We'll see as we get into the use in infants and maybe in prevention if we don't get that benefit. So we may still get there. And then we're seeing, I guess I would call more traditional medications that are being looked at specifically in patients with tuberous sclerosis associated seizures, so we can kind of look at what is their exact both safety and efficacy profile in this population instead of just pulling them from other populations. Cannabidiol was the first one to do that and document efficacy in that population. That has been great. And well, many of our patients are able to access that medication. That's not been universal. And I think there's some physicians that are still not aware that medication did do a specific TSC-associated seizure trial. And we have real data from that on kind of dosing, safety, and efficacy. So Lisa, maybe you can help us out here, but I guess as a parent, what advice would you give to, I guess, parents or even, healthcare providers when they're having these discussions with families?
It is really hard to recognize when something is a side effect of a medication or a side effect of TSC or the seizures associated with TSC. With Evan, we've had pretty much every imaginable side effect from, run-of-the-mill drowsiness as he's adjusting to the medication to, double vision, blurry vision, toxicity on meds, increased seizures due to medication, giving the opposite reaction that you're supposed to get. But we've been really through the gamut. And I think one of the things that our family has always found really hard is that it seemed like for, a good solid 15 years, you are always titrating up and down on something. And some medication is new. And we fought really hard not to just add something new in, but to take something away also, because we didn't really want him to be on, 10 medications. So we tried really hard to keep the number down to 3. And that's something that hasn't always been easy to manage, because it is kind of hard when you're taking something away and adding something in the same time frame or very close together. But the side effects can be challenging. And I think the biggest thing I would say to a family going through this is to, not to keep those communications going well with your physicians, not give up on the idea that something can work, because even though you may have tried it before, it might work in a different combination. We definitely can get to a point where we feel like we've tried everything. And our family is sort of in that situation. But, there's always something that can make a difference.
You need both sides to kind of back and forth with the good rapport with, I think, the family and the physician to sort through a lot of those things. Because a lot of these kids, and as they grow up into adulthood, are very complex medically to try and tease out what's best for them as well.
I think that's the major point. What's best for them, because you never know whether you should go for the number of seizures or the cessation of seizures or the quality of life in the patient, because it's sometimes you can add another drug and another drug and another drug, and even reducing the number of seizures with the new medications, but increasing the risk of toxicities. And what is best for the patient? What is better?
I think your point is great. And this is, I always kid my colleagues, I always say, what we've just talked about really is precision medicine, right? I mean, it has a different context in the modern era, but I mean, you're really trying to, fine tune and adjust medicines for that single patient to make it, fit them instead of, everybody fitting into the same box kind of thing, same dose, same medicine. And that's really precision medicine at the end of the day. So, Lisa, do you want to maybe address the things that the caregiver can do to kind of maximize the patient visit with their physician, how they can prepare in advance so they can get the most out of that visit?
Yeah, absolutely. I think one of the things that, my husband and I created seizuretracker.com in full disclosure, and it is a really useful tool that's being used across the board by a lot of families, but it really was created originally as a communication tool to help with exactly that. It's hard to remember all the seizures and frequency that you might have experienced at home, and then when you get to the doctor, to relay that information. So it's a great way of storing all the information so that you have it at your fingertips and can look at it with the physician or send it ahead. And I think it can be really helpful.
Thanks so much. I appreciate your input into this segment, and I think it's been a great discussion.
Hello, my name is Katarzyna Kotulska. I'm the professor and head of the Department of Neurology and Epileptology at the Children's Memorial Health Institute in Warsaw, Poland. And today I'm joined by Professor James Wheless, the professor and chief of pediatric neurology at the University of Tennessee Health Science Center in Memphis. And we'll be discussing in this section the potential for preventing or delaying the onset of seizures in patients with tuberous sclerosis. As you know, there are several trials to prevent or delay the onset of seizures in TSC. One of them, the EPISTOP trial, which was the European trial using vigabatrin to delay the onset of seizures, has already published its result, but there are some others. What is the goal for the preventive strategy in tuberous sclerosis in the genetic disorder that is already there when we start any treatment?
Yeah, I think, tuberous sclerosis was unique as a disease in that as we understood the basic kind of genetics, the underlying pathology of what, drove the disease, and as animal models were developed, one of the things that I guess we realized was that there was such a high prevalence of these children that if they have the disease, they're going to have epilepsy. And so that led to the, I guess, maybe logical conclusion of gosh, many of these children, then if we know that it's the vast majority are going to have epilepsy, we understand kind of what's, the genetic change causes in the brain. Can we do anything if we can identify them even before they start with their first seizures, and which is in the past when we would see them? If we can identify them at birth from either their heart abnormalities, from skin lesions, from other manifestations, is there any role for medicine to, prevent totally? In an ideal world, we love our medicine to say, gosh, no seizures, cognitively normal, developmentally normal, no behavior problems. That would be the ideal. And the animal models suggested that we could at least do prevention for the seizure. So I think that's what led, to the human trials, which have been, exciting. We really don't have this in other areas of epilepsy we deal with. So this has really been an exciting and kind of innovative area to say, can we do something to minimize the impact of just these ongoing seizures and the effect they have on the child and the family? And if we can, does that improve their development? Because we know these first couple of years of life for the infant are just critical for their cognitive development, for speech, and for not developing some of the behavioral abnormalities. The more normal we can make that. So I think that's what led to the trials. I know the center you're at and yourself, you were kind of critical person involved in these trials. Maybe you can give us your sense of kind of the trials and where you think we've come with vigabatrin, which was the first agent, and where things are headed.
So vigabatrin was the very first one to be tried in both EPISTOP trial and in the PREVENT trial that is still ongoing in the US. And in both of these trials, the primary endpoint was the time to first seizure. So it reflects the idea that with the later onset of seizures, the neuropsychiatric outcome would be better. But in fact, in the EPISTOP trial, in the results that we had at the age of 2 years, we didn't show that. Because the overall outcome, the overall neuropsychiatric outcome in this cohort was better than in any other outcome. So the surveillance with EEG and the early recognition of seizures was much more important than the difference by 2 weeks in the introducing the treatment before or after the onset of clinical seizures. I think we will learn much more from the trials that are focused on the neuropsychiatric outcome in the TSC infants, like the STEP 2 trial or the VIRAP trial that is currently conducted in Europe, because they focus on the neuropsychiatric features of TSC, and they use mTOR inhibitor, so the design is completely different.
So we discussed a little bit the prevention trials associated with vigabatrin. The mTOR inhibitor sirolimus has also, prompted people's interest as well. And those trials are just starting. The vigabatrin trials were kind of the first ones, if you will, to be done. So there's a couple of those involving infants. Some starting is literally at the birth or shortly after birth. There's 2 of those with sirolimus that are looking at kind of prevention of seizures, improved cognitive outcome when the child's as they get through the first year of life. There's a comparative trial that will look at sirolimus compared to vigabatrin that will start with infants. So as they get kind of 4 weeks old or so, and then we'll look at how do those folks do with seizures as they get older, even the burden of tuberous sclerosis, as well as far as central nervous system tumors. And we'll know those down the road. All of those are going to be a couple of years before we have final data on that, but those are exciting studies to complement the ones we previously had on vigabatrin. So we've now had a fair experience, just as you have and many of our other colleagues, with using vigabatrin in infancy as a preventative. I think we've kind of got the maximum, if you will. We understand that the best we're going to get out of doing that. And we see the mTOR inhibitor as the next logical step to say, can we add to that, if you will, or can we do better? I have to admit, in our center, we identify kids at birth since the beginning of this year, end of last year. We've been using both agents together. We feel like we can safely monitor them and do that. And again, we discuss with families the risk. These families understand that, my child, has very high chances of developing epilepsy, very high chances of having cognitive and behavioral problems. And it's been interesting to monitor the EEGs and see them, continue to be good. Obviously, we'll see if that combination gets to the holy grail of improved development as they get, out 2-3 years. So we all got a little while to wait on that data. But I think for a lot of these families, it's very encouraging. And I think it's nice for them to know that, we're trying to tackle this, kind of at the front end rather than waiting till they develop a problem and then saying, oh, now let's see what we can do.
The challenge is to diagnose the infants early enough to have the time window for the preventive strategies.
Our standard anti-seizure medications, and even those that have been, kind of tested specifically in tuberous sclerosis, historically have been aimed at targeting seizures once they're already present, not as prevention. So we don't have as good a data for some of those as to, will they work for that? We can test those obviously in the animal model and say, does it show any inclination of working there? But I think it's going to be a while before we know if our standard medications and even our recent ones that have been approved in treating tuberous sclerosis, like cannabidiol, will they have a role in that or not? Currently, the current studies will have to finish first, so it may take a while before we get to that, I guess.
Thank you very much for this interesting discussion on the preventive care in tuberous sclerosis. I think we'll see much more in the future with the published results of the ongoing studies. Thank you.
In this third section, we'll look at emerging agents and their role. My name is Professor James Wheless. I am Professor and Chief of Pediatric Neurology at the University of Tennessee Health Science Center in Memphis, Tennessee. I'm joined today by Professor Katarzyna Kotulska, who is head of the Department of Neurology and Epileptology at the Children's Memorial Institute in Warsaw, Poland, and by Ms. Lisa Moss, who is Vice President of Donor Relations at the TSC Alliance, and is also a mother of a child with tuberous sclerosis complex. She is based in Silver Springs, Maryland, in the United States. As I said, we're going to discuss now kind of emerging agents that will hopefully be there in the near future for patients with TSC-associated seizures and how they may improve the outcome and advance our ability to control seizures with minimal side effects in this hard to treat population. And Lisa, maybe it's worth me starting with you, because I think as physicians, we're always excited when we have new therapeutic options, but we have so many options nowadays. This is the challenge I think we always face when we talk to families is, how many options, do you have to have, failed, or how many options have failed you, if you want to think of it that way, I guess is a better way to put it. Before you're ready to think about, a new agent, a new trial of a new drug that we know some about, but, instead of just, continuing to try already, approved other medicine.
First of all, I have to start by saying every parent is different, so I can speak about my own experience. And I know some families are more hesitant to try new things, but in our family situation, we've always been really excited about trying something new. We've had highly intractable epilepsy with Evan his whole life, and so trying to find that right thing has been really important. And we've been willing to try everything. And so as soon as something else becomes available, we start following it and looking at what's being printed about it, what's being said about it. So some of these medications, as they come onto market, we've already done some due diligence in reading up on them before we even get to the physician's office. And I know we're not the only TSC family that does that. We tend to be a very forward-thinking group, and in terms of our advocacy for our kids.
Yeah, I think it's hard for a lot of families to kind of the idea of a newer medicine, and do we know enough for that to feel safe to move forward with it. Professor, do you want to maybe touch base on some of the ones that are either just starting or on the horizon as far as options for some of our families, and just maybe mention some of those?
Yeah, there are some trials that will be conducted in many countries, including the trials with basimglurant, for example, ganaxolone, soticlestat, fenfluramine. So there is a lot of drugs that will be tried in tuberous sclerosis, but I think that you raised a very important issue, that for some families who are trying more and more drugs, this might be challenging to decide whether to go for an approved therapy or to try something else earlier before trying every approved option that exists.
So maybe to give a little more detail about some of the either just recently kind of finishing up trials and some of the new ones that are coming up, I'll touch on a couple of those. There were a couple that involved prescription cannabidiol. So the GWP CARE 6 trial, which was looking at adding cannabidiol to existing treatment, and then that's gone into open label extension, where in folks that are responding, you can not only adjust the dose of the cannabidiol, but also look at altering their background medications. That has shown improvement that was sustained in seizure control in patients in the trial. I would say the side effect profile confirmed what we'd seen previously. There were no new side effects, no new surprises from that. So that was good, but it was nice to have kind of the dose range sorted out with that trial. Separate from that, there's a couple of other trials that have gone on with cannabidiol. So there's one now looking at infants going down to the first month of life up to the first year of life. We know these children can start with seizures at age, so we need the kind of data of kind of looking at dosing. How do they absorb this medicine? Do we need to change dosing? And are there unique side effects in that group? That study will hopefully be finished about not quite 2 years from now, in the summer of 2024. So we'll know more about the use in infancy then. We have a new agent, ganaxolone, which is just starting trials in tuberous sclerosis. So there's a large phase 3 trial that goes from age 1 up through adulthood to 65. That's looking as an add-on therapy at seizure reduction that will go on for the next 2.5 years. There is a separate ganaxolone trial that's an open label trial that is, again, looking at add-on, this time at age 2 to 65, that was published. That was kind of the pilot data, if you will, that led to the phase 3 trial. And those patients will continue to be followed. We'll have open label kind of experience and more safety data with them. And then finally, the other recent is a phase 2B trial with the basimglurant. It's looking at patients age 5 to 30, and again, looking at add-on and change in their seizure frequency. And that will be done in about 2 years too. So it's exciting time for these trials that are going on with an agent we've had, cannabidiol, for a little bit, but then a couple with novel agents as well. One of the compounds that we currently in the States are able to use in adults, kind of on label, cenobamate, has just had very impressive efficacy there. It doesn't work for everybody, but it's for a newer agent, it appears to have really robust efficacy. As we get a liquid and approval in younger children, I'm sure we will quickly move that to our tuberous sclerosis clinic, and it's an approved drug, which means it will be hard for some families to say, gosh, this looks so good for partial seizures. Maybe I should try this before I try experimentally. It will create some conflict, I think, between both families and even investigators. From my standpoint, the key is to make a decision rather than kind of sitting where you are and kind of move on. If it works, great. If it doesn't, you can always go to the other one, right?
Definitely. And I think it's important too for our families to know how important it is to participate in those studies and trials as well, because that is what's going to change the medications that are available to the whole community. So it is really important that that people engage in trials. And it's challenging. I think sometimes some of the exclusions with trials can be very challenging for our families if there's too much exclusionary criteria. That definitely has been difficult in the past. So, but when it lines up, it can be great, and to see some of the successes of some of the trials that are enrolling has been really positive.
I think the other kind of thing that the trials help us with is maybe kind of rethink how we sequence the different medications, because sometimes we say, gosh, yes, we've just shown that this medicine works, but if it has a good safety profile, then we may say, okay, now we know it fits in tuberous sclerosis. Maybe, instead of this being the, 14th or 15th on our list of something to try, we move it up to third or fourth or fifth. So it may help us, with that sequencing, which in my mind is actually critically important as well, too, as we get more options, is how do we think about where to place them? And based on a lot of the different seizure types that some of these kids are having, right? We know that can change over time, but, trying to, again, fit our treatment to that child and trying to do it. Professor, I don't know if you want to touch on it, but I think that's one of the areas that, as we get more and more agents, is just this idea that, I don't know, we want to call it as treatment consensus. I don't, guidelines seems to imply we know more than we do, but at least some idea of, where, infants, seizure types, where we should be going, older kids, kind of, how that may help us sort some of those things out too, even.
Yeah, for sure we need guidelines, for sure we need recommendations, but currently I think we are at a very interesting moment, because we see some new agents that might have potential for disease modifying effects. Like, for example, it was shown for fenfluramine and Dravet, when you see that it's not only anti-seizure medication, but also modifying the natural course of the epileptic encephalopathy, which is the case in tuberous sclerosis. So I think we need a kind of a consensus on the combination of anti-seizure medications, the disease modifiers, and mTOR inhibitors, probably for the treatment of other manifestations of the disease. And that's challenging.
I think we're all happy, and our patients are happy that there are more and more treatments that are being looked at in this area that was ignored for basically decades. We just borrowed our medications from our other patients. So, to see, agents like cannabidiol being used in infancy, to see trials with ganaxolone, to see basmglurate, trials starting, other trials starting. I mean, I think we all appreciate that we need these. We need options for our patients that kind of standard options are not working as well for. So I think we're all excited about that. The challenge is going to be, as we get all these options, to figure out how do we put that all together and make sense, because sometimes having too many choices is almost as bad as having no choices, right? Or limited, and sometimes is overwhelming in the other direction. So I think we're happy that those are there, but it's going to require some work, I think, down the road as well, to figure out where to place them. So thank you very much for your discussion.